The knowledge base of what we do in medicine needs to have advanced to the point where you understand what a cell secretes, how cells communicate, and what growth factors are, and what an exosome is, and the different types of things. The medical industry as a whole, and in particular, I think Big Pharma, realized very early on that cell therapy was the way the human body works, and they had to get ahead of the narrative before the science of using your cells to help you heal got kind of out of control. Welcome to the Zero Downside podcast. I'm Dr. Wade McKenna. We are sponsored by, as always, MoabTexas.com. Today, we are honored and pleased, because this is going to be fun for me. We get to have one of the physical therapists that if there's an athlete coming through Dallas that's had an injury, they know who this woman is. And I have been introduced to her ancillarily in the beginning, but she's probably the only therapist I've ever had actually bring a patient to the clinic and be there for the exam to make sure that we understood everything she was seeing during her exam of spending hours with an athlete, where most physicians are spending 15 minutes with an athlete. And the therapist many times has a way better idea of what's really going on with the athlete and their injuries. She's co-founder of Built For It, a really nondescript gym that you have to kind of look for the sign where they are in Southlake, at least. They have other locations too. But when you walk in, you know where you're at for sure. She's co-founder. She's a licensed physical therapist, sports medicine therapist, doing manual medicine, dry needling. Even with all the paper, it's more about who she is as a person and the connection and relationships that she builds with her patients and athletes. With all that being said, I'd like to introduce Kecia. Right?
Yeah, that was a great introduction, first of all. But one thing I want to say about you that was awesome was how your office welcomed me in, right? It wasn't like, oh, no, we're very confidential with our athletes. You'll let me walk straight into your clinic. The first time that I met you, I was like, hey, I've got these, professional athletes. I need to get in to see you. I love what you're doing. So I appreciated that aspect as well.
Oh, look, everything that we do, because you're not going to read about it on Google, Bing, and Yahoo, usually. They hate just the word stem cell. But it's more patient education. And for me, when I get to talk to someone that knows what they're looking for, most athletes, it's very easy to focus on where you hurt, not what's causing it. And with a really good physical therapist, you're going to be able to watch someone through certain range of motion exercises, and you're going to know what's really causing their pain. And then it's kind of like a patient education process, right?
Absolutely. And I can't tell you how many times a day I say your site of pain is not your source of pain. Almost every single time
still in
that you see someone. And so a lot of times my athletes will look at me like, why are you going immediately to my back? I'm like, well, just off of your subjective history that you told me, I can tell you right now what's going on. And then just the first thing that you tell them, like we discussed earlier, referred pain or so. Yeah. I would tell them, like, remember, site of pain is not the source of pain. It's just taking, that extra step. I think that you and I have discussed like Western medicine so much from a standpoint of what you do versus what a traditional orthopedic surgeon would be doing versus the discrepancy in the range of the quality of PTs that you get, is terrifying.
For sure.
Because you can walk into a clinic and you see the PT one time for an evaluation, and then you're stuck with someone who has no credentials, and they're in charge of, managing your entire injury through the end.
Go sit over there and do this for 10 minutes.
Yeah,
and they have some aide watching them.
You have some aide watching with a piece of paper, and they're just like checking off exercises. Versus someone coming in and you're assessing progress, and are you meeting, protocols? Are you meeting the goals that are established? Are there any weird signs that suggest that you're not healing? And
are you doing it right?
And are you doing things right?
What's the position of your elbow?
And people think it's so simple, and but sports medicine is not simple. You have one job, and it's to keep your athletes healthy and on the field. So one of the best things about now being able to work with you is I don't just see an athlete for 6 weeks and discharge them because their ACL is healthy, right? It's like, hey, this next off season, so that we don't have to deal with these chronic hamstring issues or this patellar tendinopathy, having someone like you on our team, we always have to have a team. Like, I firmly believe you always have to have a team.
Right? Like, let's work on your core to maybe make sure the ACL is not a chronic part of the problem.
Yeah,
right?
and assess your feet. You and I said that a million times with people, that every single person with a knee, you immediately are like, take your shoes off, let me look at your feet. So it's just good to have a team of people that are looking at things from like a bird's eye view instead of just like, oh, your knee hurts, let me treat your knee.
Man, it's made my job a lot easier. When you bring an athlete in, I know two things. I know one, the kid probably understands what's going on now because you've made sure to reinforce and teach him about his injury. And I also know that they've been assessed to the point where I get to kind of stroll in and do the cool part, right? Like my job is we leave a big wake, right? Like, I mean, there are times where I have to give someone a 30-minute science lesson when the science of what we do is way better than the Western medicine kind of corporate-sponsored version, the pharmacologic prepackaged version.
Right, prepackaged.
Because they know what they're going to do before they even see you. Very rarely, now because you've been doing this a long time and because I know your skill set and because you're an athlete and because you're a combat fighter, I know that you understand proprioceptive reflexes and you understand, the difference between twitch fibers and long fibers and stretches and like, I know they're not going to go to you as a therapist and you have to stretch before you do this, right? Like that's all that, the nonsense, the old school stuff is not even valid.
Yeah.
Right.
But it's still living in the training rooms and living in, to the outside world. They think that you're a professional athlete, you're a collegiate athlete, that you have access to the greatest, most up-to-date healthcare. And I'm like, no, the greatest, most up-to-date healthcare is what you're doing. Yeah.
Well, we both know.
And like being on the edge of that healthcare, but that whole like, oh, well, my hamstrings hurt. Okay, stretch them. You have tight hamstrings. Like, that is so, what are we getting a doctor in physical therapy for if that's what you're going to tell your patients?
Because
you waste a lot of time in school to not utilize what they teach you. If
for sure.
If
because
that's the way that you're going to
dumb
treat.
it down. You're expected to learn how all this works, but you're not expected to do that.
Yeah.
Right? Like, here's what they want from you. And you can tell by whatever banner's hanging in the stadium that the athlete is coming from. Because that banner hanging, if it's Blue Cross Blue Shield or Methodist, like, you're getting their little prepackaged corporate version of that because it has to have a code. That's what I was going to say. What you covered, which is the thing I like best about you and your gym situation and the trainers that you work with, and because Kecia has a lot of trainers underneath her, other therapists she works with, and she's now kind of become their fit-in management over the kind of care programs of people, right?
Yeah, absolutely.
And so the difference in that, though, is when you were just talking about they come in to see some guy who they farmed off to an aide, they're told to go do this for 2 minutes. You know the reason that happens? Because they get paid the same.
You get paid the exact same amount.
Because the code
now you can see 6 people at one time.
The code pays the same, and you don't get... one of my best friends, who's one of the people that introduced us, I've literally been in meetings with him where someone will be talking, and he will have said the same thing twice, and he'll just get up and walk out while the guy's talking because he's done.
Yeah.
Right? And I'll be, and I'll be sitting there, and someone will look at me and go, "Is he coming back?" I'm like, "I don't think so." Like, I think, and he's like, "Well, I said, he said it twice. Like, you get it or you don't." And I walked out one time and I was like, "Dude, like that was pretty harsh. Like, it's the Irish goodbye, right? Just get up and walk out." And he goes, "Dude, your profession drives me crazy because medicine is the only profession in the world where Mick Jagger makes the same as the house band. And in therapy, the code is the code is the code. So you don't get paid for your knowledge base or doing the right thing.
Oh, no.
Matter of fact, doing the right thing and spending the time with the kid for muscular re-education and some of the modalities that you guys want to use, there's no code for that.
No, and
right?
you're actually penalized for it.
Yeah.
You're penalized for not being a part of a huge corporation that's contracting, guaranteeing you a certain amount of patients.
Paying you per unit.
Why are you spending an hour with your patients? Because that's how I want to run my business. And my patients get better. Y'all's don't. So I end up seeing your patients for the second round of their insurance because they didn't get better the first time.
And you used up all their, and most of the time they used up all their benefits, right? To not get them better, because that's what they were doing. Their goal is to burn through the benefits, not on, and I want to think it's not intentional, because I'd like to think that people are more ignorant than evil. But I've said before, if you present yourself as really knowledgeable and you're not doing something right, then that is kind of evil, right? It's a misrepresentation of your skill set. So even though they may be not necessarily knowledgeable enough about what they're doing, so they're just burning through your benefits, and when you don't get better, sorry. They knew you weren't going to get better with what they were doing to you, but yet they were presenting themselves as the expert. So maybe it's not blameless. You know, we hold people kind of blameless sometimes.
I don't, at this point, I don't think it should be blameless, you know, because I would say a big portion of my clientele at this point has come from cleaning stuff up. So I'll have a doctor call me like, hey, we got this athlete. He's been going somewhere else for the past 6 months. It's really, you know, we've looked at his images. His surgery's great. Everything looks fine and tight. Can you just like fix him? You know, and it's the easiest thing. I'm just like, what have you been doing? Okay, forget doing everything that you were doing. We're going to change everything that they've been doing to you for 6 months. Yeah, for the past 6 months. You know, and so I love the puzzle pieces. I'm very much like you. I've seen your clinical exams where you love to like get the puzzle pieces. So I love those cases, but I'm also like, how did this happen? And then it makes me feel I'm embarrassed for the healthcare, you know, because I'm like, this PT
it's humbling,
just
right?
Embarrassed. This made us, you know, look bad. Like US PTs look bad
because
after your name this was an overseas basketball player, you know. But I'm like, the easiest thing to do is rehab an ACL. If you're a sports medicine physical therapist, that should be your passion, and you should be able to
focus on how to prevent the re-injury
and how to prevent it and do full body holistic. And I'm like, you've been doing the same thing for 6 months. Like, we know that you're not better. So I hate to make a good living off of like the
everyone else's mistakes.
Shows, but
I would tell you what you guys can do that an orthopedic surgeon can't do is prevent ACL injuries. Right? Orthopedic surgeon sees them when they tear it. The right therapist, especially in female athletes, just by focusing on the different exercises, and this has really only come about in the last 10 years, and I'll promise you most orthopedic surgeons don't even know about it, is when a physical therapist works with an athlete on core and musculoskeletal reeducation, you can lower the ACL injury rate in female athletes by like 50%.
Easily.
But why do we? You know, there's no code for that.
I mean,
Kecia.
there's definitely not a code for it, and there's definitely another. You know, we can talk about like, you know, the barriers of entry, right? You know, people wanting to hoard. You know, the way that the professional athletes, the way that professional sports organize their sports medicine is completely archaic.
Yeah.
But then you get to the high school systems too, and you have these 22, 23-year-old kids who just graduated college who they've never taught a gym class or maybe even worked out in their entire life, and they're responsible for these kids. So like, well, we have a strength and conditioning program. They shouldn't be. And I'm like, they're doing their squats wrong. They're doing their lunges wrong. This girl wasn't educated on her flat feet and her valgus, so she's already at risk. We don't know landing mechanics. They don't know. You know, and then you go try to sell this to other orthopedic surgeons. Like, hey, I know you run your own PT clinic, but I'm just letting you know we are down the street and we run ACL prevention courses for females. If you want to bring the whole team in, it's still not a whole team approach. It's every single athlete. Because I might look at this.
Problem.
They have a different body type. I'm like,
there's no allowing for individuality.
For soccer. You are not primed to play soccer. So let's try to keep you as safe as we possibly can. You know, but then orthopedic surgeons, they don't, you know, there's still a barrier. And the coaches are like, you can't come in here and teach her. I'm like, it's a free clinic. Why would you not let me come into your gym and teach your kids how to lift weights or teach them body mechanics or ACL prevention? Like, well, no, we don't outsource. We don't.
Every great
but we'll
athlete.
Do our ACLs when they do tear them.
Yeah, exactly right. And oh, by the way, we're going to do it in a way that has a 30% risk of return the first 3 years back at sport.
Oh, yeah.
How is that not considered an abject failure? The redo rate in a female soccer player is 30% in the first 3 years. If you use allograft tendon, like, oh, I'm using autograft tendon on this person. Yeah, when you cut it out of the person and lay it on the back table before you put it in them, it's just as dead as the allograft. And now you've created a mark that may not recover, because we don't even talk about harvest site morbidity anymore, right? Patella alta, infrapatellar tendon, patellar tendon tracking disorders, all the stuff that they're never really maybe going to get over with anterior knee pain, adhesive capsulitis, patella maltracking syndrome, patella baja because the tendon scars in. We don't address any of that, because look how pretty my picture is. Like, there was no ACL, and look, there's this. Oh, it's so pretty. Like I'm so.
And then, but then I'll get those athletes, right, that are they're doing their rehab at the facility. I'm like, has anyone put their hands on you? They're like, no. I'm like, so how do they know how your patella? Did they take
your tendon
they
sets.
grafted your patella, right?
A third of your tendon now is popping
It's
out
now
of your joint.
So we don't need to mobilize your kneecap, make sure that there is proper tracking. The people, and I'll get guys 3-4 months out that are going in and having scopes because of cyclops lesions, and I'm like, because nobody was mobilizing you. They were just put you on a table, do your ACL exercises, your straight leg raises, and your 4-way hip. Like, don't get me wrong, I understand it's necessary, but there's a whole nother aspect to it that's necessary.
Right?
Yeah, because there's no reason I'll get a guy that has 100 degrees range of motion at 4 months out.
With
Why
no
does he
VMO.
not have full,
And
with absolutely no VMO, and the
no
worst
glutes.
patellar tendon pain you've ever seen?
Yeah.
And no one said, like you said, patella baja, where it's short.
It starts to shorten up.
And if you're dealing with an African American population and you don't educate them on, hey, this is the importance of, you do have a higher tendency of scar tissue production. You do keloid. Yeah. You need to have someone
just because you don't
looking
see
at
it
you
on the
every
outside
day.
doesn't mean they scar
Doesn't mean
normal.
it doesn't exist.
Right? Like wounds.
No.
I take
it personal when my patient has an MUA. I take that shit very personal because I'm like, how could we have avoided this? I look at you every
I wish
single
most surgeons
day.
took it personal when
They
their
have to go
patients
and do
have
it.
an MUA. Yeah.
Yeah.
But you know why they don't? Because it has a code, right? And guess what? Now, do I like doing MUAs? No. Do I think they're really underutilized sometimes? Sure, because if I can mobilize someone that maybe doesn't have access to someone like you, I can maybe shorten the recovery. Do I do a lot of that just with just sedation anesthesia in our clinic? Some, yeah, because I can't kind of push them to the hump a lot. Maybe they're not, especially 70, 80-year-old women with dramatic hormonal issues that are going to scar in when they
High
put them in a
pain
sling for a week.
intensity,
Yeah, right. I mean, especially with symptom magnification. But even like a rough mammogram can cause a lot of women to get frozen shoulder.
Absolutely.
And no one will diagnose it. Or when they'll look at the MRI, they'll go to get an MRI. The guy said, I don't see anything wrong. And the patient will be like, but I can't move my arm and it really hurts, right? Yeah, well, the MRI shows there's nothing to operate on. We'll just send you therapy. Therapist looks at them, hey, they can't move their arm, like something's wrong. They need an MRI. Well, the MRI was normal. They'll be a year out, and they'll finally find their way to someone like you or someone like me, and they'll come in and go, they'll be almost despondent, like depressed, because like, I know I'm not crazy. They said that there's nothing torn. I can't move my arm, it hurts all the time. And I'm like, well, what all have they done? Well, they put some steroids in there. Did that help? No. Oh, okay. Well, I don't know how steroids were supposed to help your partial thickness tear that resulted in adhesive capsulitis because you weren't moving your arm because it hurt a lot, and because hormonally you're out of balance. You got Hashimoto's, your testosterone level's 10, and you're 70. Like, you're going to have a frozen shoulder, right? You'll examine them, and you'll be the first time that they've ever been told they can't have external rotation or can't raise their arm. I'm like, well, what did they do? They just looked at the MRI and told me there was nothing wrong. From an objective standpoint, if you're the patient and you're told you're fine, but you know you're really hurt, that would result in some secondary depression, right? So then what happens is we group them into, they're a symptom magnifier, they're kind of crazy, they're postmenopausal, right? Like, and especially, and I'm not going to rage against men, although I do have 3 daughters and no sons, so, #girldad. But but I will tell you that Western medicine is notoriously paternalistic and sometimes not very patient-based. We're algorithm-based, and we want to treat illnesses, not people.
Not people.
And just to be able to look someone in the eye and say, oh, well, you have adhesive capsulitis, and here's what we're going to show, and I'll print off something for them and say, look, here's some exercises. Do this. We're going to put you on some anti-inflammatories, but there is a really easy process where I can inject some fluid down the capsule, break some of that loose, move your arm around, maybe we get you better, but you're going to need therapy because it's going to come right back if we don't get you moving, right? We'll take them on Amazon and show them how to buy a wall pulley. It's $20. And they'll be like, well, do I need, like, unless you're really disciplined, like, you need a pulley. Like, set your butt behind a door, put a pulley behind your back and start pulling your arm up, right? We'll treat you some muscle relaxers, do it an hour after, but you knew that diagnosis without looking at an MRI, most of the time by history. But you're not going to put someone in an algorithm without looking at what's their deltoid strength like, what are their secondary scapular stabilizers, like how's your other arm range of motion, do you have bad arthritis,
and
right?
have we, you can go through a clinical exam and decide whether or not this is going to be something like, I need to refer out, this is surgical. So there's this huge AMA block against PTs having absolute direct access. Other states have it, Texas
Colorado
doesn't have
does.
it. We have 10 days of treatment, right?
Yeah.
But they don't like it because I don't need, if someone sprains their ankle, you don't need to go and get an MRI and an x-ray. I'm going to conservatively treat this because I have the skills to know, this actually looks like it's a fracture. Let me send you to the doctor and you need to get an x-ray.
Do you know what? The MRI doesn't change
But the MRI
outcome.
doesn't change the course of treatment.
No.
So even my patients with shoulder problems, I'm like, stick with me for 4 to 6 weeks. I promise you, you're going to get better. If you don't, then we will get an MRI.
Not only that, but you'll know what you're looking for.
Yeah.
The random MRI, you're trusting, especially, God, and I don't know how to do this without sounding like a little bit,
It's okay to say.
Well, I think you can sound like a prick pretty easy sometimes if you. But I think a lot of physicians, a lot of physical therapists, but even orthopedic surgeons, they look at the report. You know what? Especially in the days of homogenized care, especially with, like, I have very few radiologists that I have a really good relationship with. I can call them on the phone and say, hey, look, I'm looking at this film. On the stir, I see this and this. Do you mind relooking at, like, and I go, oh my God, you're right. Like, or maybe, but if that X-ray or this MRI is being read in India by a guy that's getting paid $50 to read an MRI in 5 minutes and generate a report, there's a lot of times that report is just put report number 1, put report number 2, put report number 3. And it's not even a customized report really looking at the films.
Yeah.
And so if you're the surgeon and you're not looking at the films and you're not examining the patient and you're going by the report, your chances of getting it right are negative anyway. So the MRI didn't add to the care.
No.
It just told me, like, especially with that paradigm algorithm that they're going to put to someone in, because a lot of times it's not even the physician, it's the PA or the nurse practitioner.
Oh, absolutely.
Who's not maybe, I had a unique advantage because the MRI technology, this is how old I am. Like, that's like the shout. And no one is going to think I'm young anyway. But when MRI technology really became a thing in patients, when I was at Oklahoma State studying physics, the process of MRI technology was called nuclear magnetic resonance, NMR. And we were using it as part of the aerospace program to look for fractures in carbon parts. And so the physics of, that T wave and like flipping the electron, like, it was fascinating to me. But there wasn't really the human applications of that were being talked about. But in 1983, that wasn't a thing yet. There was some early kind of things that maybe with MRI technology, but a magnet was giant. You would spend cryogens, like there was like $20,000 a month in cryogen cost to cool down the magnet to be able to even run an image. Now you can put it in a truck and pull a patient in, right? So, but because I was around as they were developing that technology, people would bring the films in. We'd have them hanging on the wall while you have a scope in a knee. The X-ray residents, especially the teachers, because there's very little overlap between CT and MRI anatomy. And so the guys that have been just trained in CT forever were having to learn about MRI too.
Right.
At the same time we were. So as an orthopedic surgery resident, instead of just throwing away access to knowledge that was just beginning because I was fascinated by it, we would have all the films hanging, and I would want to stick a scope in the knee and try to correlate the arthroscopic anatomy with the MRI anatomy because it was fascinating to me. So it would have been hard to train as an orthopedic surgery resident in the early 90s. You kind of almost had to duck your head in the sand to not learn about how to read an MRI. And I think it's pretty crucial to learn how to read an MRI because otherwise you're trusting someone else with your decision making, right?
Absolutely.
I think, unfortunately, I know for sure most PA students, most nurse practitioners, most family practice doctors, most sports medicine family practice doctors. Most orthopedic surgeons, especially if they're young, they didn't have to do that, right? So I don't know if I'd trust the guy looking at my MRI anyway, because unless you see some one big glamour shot image of the problem, the subtleties of the injury can be really easily missed. So now you're just getting an MRI that's not going to change the outcome because it's going to miss the diagnosis and not be talked about anyway unless it was on the report. So if that radiologist is reading 100 MRIs that night in India because they farmed it out to a contracting agent, I can't even call the radiologist that read it on the phone and talk to him.
Yeah.
Because they're all big groups, because they've made radiology where there's like, it's I think you get like $50 to read an MRI or something, right? So how much time you get paid the same for a 4-line report as you do a 2-page report.
Yeah.
They don't pay radiologists by the accuracy.
And
of the
that's
reading.
just another, like the discrepancy of things that you get, because then it's, it's also the one, like the specificity of 2 doctors saying the same thing when they read an MRI, just in what I experience. I'm like, okay, this doctor said this about your rotator cuff, this guy said this. And I'm at the end of the day, I'm like, that's all that the patient is perseverating on at this point because they've been forced to have all these images.
Because they're focused on the MRI.
I'm like, can you just let me help you?
Yeah.
You don't need surgery. You need conservative management, and you probably need someone like Dr. McKenna. So can we tag team this?
I feel blessed by
so that you can get, whether it's PRP, whether it is stem cells, whether it's the longevity of this, because at the end of the day, that is my goal. Someone has adhesive capsulitis. I don't want this to come back. What can we do to prevent this from recurring? Because I don't
steroids
like people.
Probably don't prevent the recurrence, right? I mean, let's go through everything they're going to do. Does an intra-articular steroid injection make adhesive capsulitis better? No. Does it hurt the tendon? The best way to turn a partial thickness rotator cuff tear into a full thickness rotator cuff tear is to inject steroid into it.
And
because it's catabolic.
Weaker.
But
I'm like, well, you took them out of pain for 2
code.
days, but that was it.
Yeah, steroids have a code, right? But the long
and anyone
term,
can do it. You can walk in, and your medical assistant can just do it. We're not doing it ultrasound guided. We're just jabbing it in there and keep it moving.
Well, it's a shoulder.
Yeah. Well, it's a shoulder. Yeah.
Where in the shoulder do you want the steroid? Like, there is one place I want to maybe put some corticosteroids occasionally in the subacromial bursa, if that's your diagnosis.
If that's your true diagnosis.
But am I going to blindly in an exam room be able to stick a needle in the subacromial bursa without getting in the cuff tissue or peritendinous tissue 100% of the time without visualization, C-arm, ultrasound, a little bit of guidance and help? Probably not. You might. Like a pig finds an acorn sometime. What's the old thing? A blind squirrel finds an acorn? Or pig finds truffles, right? Anyway, I think that being specific about your diagnosis is a big deal. But the diagnosis, if you're building your diagnosis based solely on MRI, you're building your foundation of care on very biblical, like you don't build a house on the sand, right? Some MRI reports are sand, and it's not going to really give you a concrete foundation to build a treatment protocol on.
And one
physical
thing,
exam does.
And it does. And one thing I would say, the transition, obviously I wasn't around when they had like a master's of PT by the time I was going to PT school as a doctorate, but I just researched, what classes are they adding? What's different between, it used to be a bachelor's, it used to be a master's, now it's a doctorate. Well, differential diagnosis, because the goal of the APTA was to get PTs direct access. So they're like, okay, well, if they have a doctorate like a doctorate of chiropractic does, which is even less school than a PT goes to.
For sure.
Then, hopefully we can start bridging that gap and, get over that hump of not having direct access. So one of the things that they added into school, though, was a heavy, heavy differential diagnosis component. So you're doing your internal medicine, you're taking, essentially like adding almost like a nursing school into it, right? So you have all of these physiology classes, all of this, you're re-upping your anatomy every single year. I mean, it's very intensive, but it was amazing because that was the one thing that helped me with my practice was differential diagnosis. So when a patient comes in, like I get everything from a subjective. They're like, "God, you're asking me." I'm like, I'm going to ask you weird questions and don't even ask me why. Yeah. Does it hurt when you do this? Do you have pain at top end running? It doesn't really hurt when you just do this, does it? It hurts when you do this. I'm like, okay, I know exactly what's going on. And they're like, how did you know? I'm like, one, it comes with experience, but two, I was so heavily focused on differential diagnosis because I had to have a script, right, from a doctor that says, patient needs physical therapy, right shoulder pain. I'm like, so that's got a code.
Yeah.
Right shoulder pain. I'm like, what the hell does that mean?
Yeah.
So then I'm sitting there going through.
You still have to figure out what's causing the pain to know what to do to treat it.
1,000%.
But here's the difference, though. You care about what you're treating. If someone just has a diagnosis of right shoulder pain, I know they're probably treating it the same way every time. sometimes you may be right. Most of the time, you needed to have a little bit more specific diagnosis than that, right?
But there's places, and I won't name names, monstrosities in the DFW area.
Giant healthcare
organizations that are still, they claim, this is where all the athletes need to go, and we're sports medicine. I'm like, well, you aren't sports medicine because that's not what you do. But they still are handing athletes and patients of all ages, a packet. Oh, you have low back pain? You finished out your physical therapy. You still have pain? Here's a packet. Go do these core exercises. Yeah. So every low back is treated the same. So I might have vertebrogenic low back pain. I might have radiculopathy. I might have stenosis.
Oh, I may just have tight hamstrings.
You're going to make me do the exact same thing that this 65-year-old woman is doing.
She has compression fractures and severe osteoporosis.
So we're all going to lay on a table.
I'm 19 with a really tight hamstring because I have a little bit of a slip. But we're going to treat you exactly the same.
Everyone is they're going to say, don't do anything for 2 weeks. Okay, well, motion is lotion. The more that you move, the better that you're going to feel. You have to keep moving because then your muscle does shut down. You go into spasm because you have neurologically just told yourself, I can't move. And then you had a doctor and a physical therapist tell you, well, you should never run again, or you should never do this again. And it is just the most, it's archaic, but the fact that it's being rewarded by insurance companies, and then people like you and I, our practice and the amount of time we spend. People. Absolutely. Right. And then we're punished for the work that we do. It's like, well, we're not going to cover that. We're not going to cover that. We're not going to do that.
And it's more like you're exactly right. And maybe I've been too kind because talking to you, I feel a little bit more enabled. Like, I think that a lot of the benefit ratio system in Western medicine is punitive to good care, right? It rewards the people that paint broad strokes. And look, here's the thing that's most remarkable about the human body. A lot of people get better in spite of what they do to them, right?
If you read the research that we read, yeah.
Yeah, because guess what? The body really physiologically has a lot of really good sound mechanisms.
Healing properties.
I'm just telling you right now, if you can enable someone just to learn how to stretch and take some of the right, eat right? If you can get them the right things in their body, and I hate when guys say, the narrative of, and we'll have a patient every week, you realize when you take vitamins, you're just giving yourself expensive urine. And my head, I want to beat someone's head against the wall, right?
Whoever told
because
you
you're
that.
like, wait a minute, so nutrition doesn't matter in sports, like. Especially in the age of the viral myth nonsense going on. Like, you know what? A little bit of zinc's pretty important, right? Maybe have some vitamin C in your diet.
Maybe some magnesium.
Hey, you need magnesium at night if you're going to train muscle.
I don't know how much you know about calcium and potassium and what they do with muscles, but
you realize that there's this positive and a negative, there's this charged ion thing. It seems kind of important if you want to build muscle. Like, God, you know how that how a nerve impulse gets from here to there? Electronic transfer is kind of important. But they'll literally tell a patient that, like, you're taking magnesium at night. Like, what does that do? And you're like, I think, fortunately, whoever designed this, like, it's a very divine device. And I say all the time from the stem cell part of what we do, because it's more about what the cell secretes, right? So there's 7,000 naturally occurring peptides in the human body. Oh, by the way, I can write you a script for about 40, but I have to know what your problem is to know what one to take. Sometimes I don't need to know sometimes with the cells, but guess what? Your body doesn't know either, and it has those cells in it. And so if you get someone mobilized right, and they're weight bearing, and you're going to see cartilaginous response to weight bearing loads, and atrophy, it goes away, but loaded, it comes back. Like, no one grows cartilage where you don't need it, even when you put cells in it.
Exactly.
Maybe your body, sometimes you have to teach your body where you need it, right? I always tell people all the time that your body really wants to heal, but it just sometimes doesn't have the resources to do it, right? And you got to do the right things so it knows kind of what to do. When most of Western medicine will be focused on how are we going to change the way you respond? No. Like, you're not going to. There's very little way to change the way this is going to do something. You can augment it, or you can get in the way, but you're not going to change it, right? So most of what we need to do is augment someone's intact physiologic response. Well, how do you do? Like, that's a lot easier to do that without getting in the way of everything, or nondescript painting some broad stroke that really wasn't going to make a difference for people, right? Most of what I mean, I think most therapy for sure. If someone's doing it right, that's the problem with therapy is you get painted with the same broad stroke as doctors do, because I went to therapy and didn't help.
I know.
And I'm always like,
well, what did you do?
What did you do in therapy, right?
Like, tell me, like, that's the first thing. If they said I've done therapy the past 3
I've
months.
done therapy for 6 months, and I'm
I don't
trying to
know
help
why
her.
I'm
Don't
here. My
send me to
doctor
therapy.
forced me to come here. And I'm like, all right, well, what were you doing? Okay, we can fix that.
It's a big hurdle to get over. The worst one for me is, well, I had stem cells and it didn't really help. I'm like, oh, Lord, no, what did they call a cell?
Yeah.
Right?
And after
Where
meeting
did they get
you,
it
that's
from?
like, I was very, consider myself pretty educated on like the PRP route, right? And
Yeah.
so they would say that. I tried that and I'm like, yeah, you went to, I call them, this probably isn't right, but I'm like, you went to a doc in the box whose centrifuge I probably could have bought off Amazon.
Yeah.
They didn't test your blood. They didn't see if you were hydrated. They didn't do it diagnostic ultrasound. They just gave you PRP. So now the same thing. If they're like, I got stem cells, and I'm like, okay.
Okay,
I
so
think
yeah.
in the beginning I used to text you and I'm like, okay.
Hey, what's this guy? Oh, PRP, like.
Because I'm like, if you didn't, some people will be like, I paid $200 and he did stem cells in my hips. And I'm like, no.
Yeah, no,
That's
I
not what
promise you
happened.
didn't.
Promise you that's not what you
I
did.
promise you. Like even a real PRP kit is $1,000, right? Because PRP, and that's the worst one, because you get some guy with some little office-based centrifuge doing a 10 cc spin.
I know.
That's not PRP. The definition of PRP is it has to be at least 5 times more concentrated than whole blood. So if you're taking 10 cc's of blood and you're giving them 5 cc's back, there's no way that's 5 times more concentrated than whole blood. It needs to be at least a 60 cc spin. You need to have growth factors above X, or it's not PRP. And PRP is incredibly inflammatory. Why? Because that's how the body triggers healing, right? You got to generate. So we're kind of stoking the fire on inflammation.
Exactly.
There are some people that's a real problem. You stoke the fire on inflammation, and their body's having a hard time getting to that next step. You made them worse. Well, I had stem cell injection. Well, how'd they do it? Well, they took my blood. And, okay, 0 chance that was a stem cell injection. Well, they took this powder out and they added liquid to it, and they shook it up and said there was amnion. Okay. I don't know a cell that can make it through powder.
I was like, how did it live?
And the cell did what? Like maybe they injected some protein. Okay, I have no problem with that. If it didn't make you better, though, that's not a stem cell. It's like the same thing. I went to therapy. So those terms and who they went to, and I want to see what you did. Like, get me your PT notes. Get me your protocol. And you'll look and it'll be like, they did. It'll be some aid, right? So usually it's filled out by PTA. It's like, okay, they did this for 15 minutes. They did this for 15 minutes. They literally just knocked out every code that they could. So you get 3 codes per
Like
visit
4
or something,
codes per
right?
visit.
Yeah.
Mm-hmm.
So you'll look and all the little things are all knocked around that code, and none of them were appropriate from a physiologic standpoint. But they went to therapy, right? And it didn't help. Like, or I had cells. So we deal with the same thing, right? Because it's
you'll just
different.
And to us, like what we're talking about right now is just daily conversation, right? But then when you're trying to educate a patient on that, imagine a doctor sitting there telling them that they are getting stem cells. They don't know. So there's such a broad term. So anytime I get asked a lot, by different doctors and athletes, like, hey, this company wants to talk to you. They do cells. They do this. They do this. And, once I start asking questions, it's just like you said, I'm like, okay, so you're not harvesting, okay, so you're not doing like BMAX cells, but you're also not doing umbilical. So what are you doing? Okay, you're doing exosomes. Okay, well then say that.
Yeah.
But you're not harvesting a stem cell. So you need to stop saying that.
Well, okay, it's even worse, because what's the definition of an exosome? Well, every company defines it differently. Wait a minute. Like, isn't an exosome as an exosome as an exosome? Because really, an exosome, as defined in the narrowest of terms, is a spherical secretion by a cell, so it has to be round, has to be covered in fat, and it has to be between like 0.35 nanometers and 1.6 nanometers in size. Is that what everyone calls an exosome? No. Because if I want to say it has more exosomes, all I have to do is make it to 2.4 nanometers in size and down to 0.25 nanometers in size. Does it have to be spherical? No, you know what? Let's call fragments exosomes. So now we have 1 billion exosomes. Well, how many of them would have fit in the original defined criteria for an exosome? Maybe a third of them? But we have 1 billion. No, you may have some fragments, but an exosome, technically, when the cell secretes it, it could be messenger RNA, which is like a stem cell can actually package its mitochondria and give it to another cell. And it does it with an exosomal capsule. It makes it a spherical and sends it into the other cell. That's not what exosomes are when you get them in a big package very often, right? Now, are there some people I think that do it right? Sure. This many out of this many, right? The same amount of radiologists that I think really care, the same amount of surgeons I think really care, the same amount of therapists that really care. I think there's this much, and you don't know if you're going by this. But I'll tell you that representation of cell therapy, if someone has to hang their hat on that, they probably have malintent, because bone marrow aspirate concentrate as a stem cell function is really, really well published. It's not incredibly difficult to get, but it's not $20,000.
Right.
Right. And it doesn't come where I can just open a package and shoot it in someone. There's a little bit of effort that goes into doing it.
A lot of effort that goes into it.
But it's really important, because if you do all the little stuff right, guess what happens? People get better.
Yeah.
Right?
And like you said, like we're trying to augment healing. So some people, they're looking for that quick fix. So like, hey, if I'm going to spend this much time in therapy, there's this doctor down. I get this a lot. There's this doctor down the road. Your guy was going to charge me $875 for one PRP shot, but he charged me $200. I'm like, then it's not PRP. And don't waste your time. But I haven't sat in one exam with you where you haven't. Yes, we talk about obviously that we are here for cells and we are here for regenerative medicine, but there's not one person that you've ever skipped over, like, what is your diet like? What is your hydration like? And, whether it's ordering them also an ancillary, here's a pain cream so that you can continue your therapy without so much pain.
Guess what I don't want you to do?
Here's some
Stop
orthotics
moving.
for your feet, but I want you to work with Kecia and get your feet stronger. So you're like, that's like the word of the day, I would say, is augment. It's not just we're trying to augment your healing by telling you to do all of these things and not have just one end all be all. Because the intent is to get the athlete better. The intent is not to just take their money and be like, oh, sorry, it didn't work. Like, that's unfortunate.
Then you become a procedure monkey, not a healthcare provider.
Not a healthcare professional.
Right?
Not a doctor. Like, you have so many skills to do what you do, but you spend the time to do it. Every time I've walked an NFL player in there with you, we're in there for like an hour.
Yeah,
That's
which is, my staff is not a big fan of that sometimes. but we don't scare. You know what? Because I work for myself. Like, I can't work for someone that tells me I have 15 minutes.
Right.
To treat someone, because that's what the appointment time is, right? Like, the code that Dr. McKenna, you don't get paid more for seeing them for 30 minutes.
I know.
Don't care.
I know.
Right? Like,
I get that.
Do I have some patients that may be frustrated if they're waiting sometimes? Yeah, and it stresses me out. Like, when I look at it, I'm just like, but I know I'm not gonna cut them short either.
Yeah, absolutely.
Right? So I just dig myself a big hole throughout the day. But at the end of the day, I look at myself in the mirror and I'm like,
I feel good about myself.
I may have forgot to take out the trash today, but right. So I have a lot of things I did wrong, but I know that I did the best I could for every one of those people to kind of give them a specific diagnosis. That's the thing that bothers me most about even the cell therapy part. If you don't have someone hormonally fit and nutritionally sound, you could be pouring seed on concrete, right? Like, the most expensive cell in the world. If I don't have a body that's going to know what to do with it, you're wasting thousands and thousands of dollars.
Wasting your dollars, yeah. And I do that, even I try to educate, because, you bring on new PTs and you're not taught a holistic way to treat, You're not taught how to put all the puzzle pieces together. But if I get an athlete that comes in and they're like, I just need my hamstrings, I'm like, are you hydrated? Do a tissue integrity test. I know that's not the most scientific, but
but it's important.
Some of these people I've worked with for 6-7 years, and I'm like, I know your body. By now, I'm like, you look like shit. Your skin feels like shit. You wore a sweatshirt in your workouts today. You sat in the sauna for whatever reason. It's 98 degrees outside, and then you come in here and tell me your hamstrings are tight. Flushing them's not going to do shit. Go hydrate yourself. So then I'm talking like, and I don't just mean with water. Like, you have to actually have true
Water's
hydration.
Probably by just note to self. Let me just let some people know. Water's not the most hydrating substance to take in.
Period.
I know that's
And
going to
you
be shocking.
I know.
But drinking a bunch of water doesn't mean you're hydrated.
Doesn't mean you're hydrated. I'm like, you're just going to pee it all out.
Yeah.
Something has to retain the water that you're taking in. But just little things like that. I try not to send you people that I know. I'm like, hey, you got some shit to work through.
Yeah, you're
before
broken.
You see.
Yeah, I
let's
can get
clean
you to where
up.
we can get you to
Let's
him,
clean
but-
up, like these hormonal imbalances, or if they have some underlying systemic diseases or whatever.
Yeah, McKenna's not going to want to stick a bunch of expensive cells in your knee when you can't straighten out your leg.
But, yeah.
Right? Like, you have no VMO function and you have patellofemoral pain. I'm betting that it's a waste of his time to put a bunch of cells in your knee unless I get you some VMO back to get rid of your patellofemoral problem. Because, oh, by the way, you might not need cells at all, right? And it may be a waste of time and money. And that's the goal. The most expensive treatment in the world is the one you waste money on, right? If you paid $200 for something that didn't work, you wasted $200.
Absolutely.
Time is money. So if someone's beating their head against the wall in therapy because they're not doing all the right stuff, seeing me and spending a bunch of money on bone marrow, is that going to make them magically better? Man, not very often, right? Like, it's really about knowing what's wrong.
Right.
And you've done, like, I love working with you guys because, I'll literally take people out of other therapy programs if especially when you look at their notes and you know that the PT, it took them 5 days to get me notes because they didn't have any. And they had to get all, right? They had to gather their treatment plan from all the PTAs that were seeing them because the therapist, when you talk to the patient, well, the therapist came over and told me to go over there for 30 minutes and do this. Did he watch you do it? No. Did he measure your strength? No. Did he, like, that's not therapy, right?
It's not therapy.
And you'll take, you guys, I can send someone over to you guys and just say, look, I just need them to learn a home exercise program because they're coming in from out of the country or they're coming in from out of state.
Yep.
Can you just teach them how to not hurt themselves? Right?
Absolutely. Forte.
And patients will be like, oh, wow, like, I love that girl. Like, yeah, that's the reason. Did you look around when you were there? Because a lot of these athletes that just fly in and out of Dallas make a point to schedule stuff around being able to see her at that clinic so that they can learn what to do so when they go back to their own therapist, they're not going to hurt them, or when the team tells them do this and this. It's a misnomer. So regular people think that if you're a pro athlete, boy, they care so you get so much better care. I've not found that to be the case.
It's gross
You have to
negligence
have
at this point.
You have to have an advocate, right? And the team is not your advocate. You're a cog in the wheel usually,
at this
right?
point, you work for yourself.
The agents care about you because they don't get paid if you don't. So I'll get more patients from an agent and a therapist than we're ever going to get from a team doctor.
Oh, absolutely.
Right.
And I work with all of the second opinion team doctors who are like, hey, we work for the athlete. We don't work for the team. So we're not going to sit here and tell you that there's nothing wrong with this kid's knee because there is. Or, so I like to work with those people because the team they're not incentivized to take
But their contract makes it really hard for them to see a guy outside of team-provided medicine.
It makes it very hard.
They have to almost do it in secret. That's the reason we both have some athletes that we've taken really good care of that have been really well rewarded, where it looked like they were going to get cut and then they get like comeback player of the year, that they can't mention you or I. Doesn't make us any less proud of them or anything, but because we both know that contractually they weren't even supposed to see us, right? They did it and then when they get better, all the mainstream guys are like, look what we did.
Oh, yeah.
And you're
Our
sitting
old
back
school
going,
ACL protocol was really working. I'm like,
and Kecia's sitting back going, man, like that kid was so broken. And if we would, but the kid knows, right? And so that player room, those kids will talk to each other individually as a side. They'll pull other guys aside, which is how people get to you. Some kid will pull another guy's side.
And the funny thing about it too is, a lot of people now that I've been doing this for quite some time, like 10 years into doing PT, had built for it for 4 or 5 years now, but they think it's, all just like fun and games and like, oh, it's so cool. And, but the thing is, like, I got into it because someone like Kayvon, former NFL player, he's my business partner, was a patient of mine. But he's, younger than me and had teammates even younger than him. And I'm like, so you're really getting these 22, 23-year-old guys who are fresh into the league just being told by this system, like, what you're supposed to do. Yeah. No one's looking out for them. The worst thing I saw him just crutching down the hallway. 2 weeks, he's still on crutches, 2 weeks from a knee scope. Did not do a meniscus repair, just a basic knee scope. No one had looked at his incisions. No one had taken his dressings off. No one had gotten him moving. No one had done his range of motion. And then once I realized that's the standard, no one's getting, and it might seem old school, but I get a goniometer out. I'm like, no, I need to know. I need to know that we're making progress.
I still will use a tuning for it for fracture
fractures,
healing, right?
Absolutely.
And people will be like, but especially with the clavicle, because they can look like crap on a film. But if it's not tentative tuning for it, you go back. Like you can bust it out. Like you're not going to hurt that.
Absolutely.
And people will be like, wow, because when you first, patients know, if you do it early, they're like, oh God, that's incredibly painful. And it's okay. The reason I did that today is because I want you to know that when that goes away, you're fine.
You're better.
Right? And people will be like, well, don't you just do films? I'm like, yeah, we can do films too. And I palpate it and I move your arm around. But there's a bunch of, the old guys weren't stupid. We've had to unlearn a lot of stuff. So technology's made people stupid, right? The best example I have is the calculator on your phone. I will watch cashiers at a restaurant not be able to count change back when I give them an extra dime so that they can just give me $1 back, right? And they'll be like, we'll keep the dime. I'm like, no, I'm giving you the dime so it makes my change.
So I can get rid of it.
But we've dumbed it down. People can't even do simple math. Do you think at a level where there's all this technology that's shrouded in medicine because it has codes and billable hours for it, what do you think is to have with the basic medical knowledge of physical exam? It's gone. A lot of people don't even, because you've sent these kids to me, when they have 4 or 5 back pain, their hips hurt, it hurts on the back leg. Oh, by the way, the random question is, do you have ever numbness tingling in the lateral calf? And the guy will be like, how do you know? They told me dude, because you have a 4 or 5 disc. And guess where the dermatome, it comes across here, down your hip, down here. And it can skip. People say, well, my back never really even hurts, but my calves are numb and tingle all the time.
Yeah.
Because the nerve may not read the book. It will eventually hurt everywhere you're supposed to. But it may not hurt everywhere you're supposed to all the time, right? And because of that, people diagnostically just kind of write them off. We were talking before, I want to tell a story because it's so perfect with what you do. Because it's wrong on both sides. And the guy's like, man, I really appreciate the physical exam and all that. He went to a stem cell clinic. That advertises on the radio a lot. And they use initials. And he said, within 10 minutes of walking in, they told me it was going to cost me $10,000 and they can inject my hip for my hip pain. And it hurts on both sides. And he says, all I could think is, they haven't even examined me or touched me or looked at an x-ray, but they told me they could make me a lot better for $10,000 by injecting stem cells in my hip. He goes, 10 minutes after I walk in. And they have this big protocol, if I come back in 2 weeks, and I come back in 4 weeks, and I come back in 3 weeks. And he said, and I was just like, So, but the traditional guy that he had seen, because he lives Galveston, which is almost out of state if you're in North Texas. And he's like, but the traditional guy's like, look, suck it up, we'll put some steroids in your hip, but you're going to need a hip replacement. I said, so did he say you were going to need both of them replaced? Because your pain is the same with both hips, right? He goes, yeah. And I'm like, but he said, just replace the one that hurts most first. So now,
hadn't touched him.
You've had barely looked at an x-ray. No MRI, no physical exam. I sit the guy on the table and I look at his films and I'm just like, well, here's what I'll tell you right off the bat. You don't need a total hip. And you're probably never gonna. So if you had a total hip, I promise you, over the next few months, you're going to hurt exactly like you have now, but worse, because now you're trying to get over a total hip. And they're going to leave a mark,
now
no
your hips
surgery.
Are weak. Now your back's going to hurt worse.
You're going to destroy your gait pattern and everything else. So, and the stem cell injection. Now, I said at least the guys that were just going to inject stem cells in you weren't going to hurt anything. The surgery was going to hurt you. But at least the guys inject cells in, but economically, that's the worst decision ever, right? So we examine him, and if I show him that his hip is in his groin, I bring his leg up. We do internal external rotation. He has no groin pain. I'm like, yeah. Straighten out his leg. Hamstring's kind of tight. And as you straighten out his leg, he kind of starts leaning back.
Oh.
And I'm like, this is a disc in your back.
A little bit of neural
How do you
tension.
know that? And I'm like, well, because it's called a tension sign. And this is called a Lesag's exam. And as I straighten your leg and bring your heel up, if it hurts in your hip and you have to let that, it's called a bench test. It's just a really easy exam. And really, I don't go through all that exam and elicit it. I like a lot of it. There's like 5 steps in my brain but I can just straighten your leg. But I'm doing all that, but without, making each one little test a separate thing, right? Because you can just kind of, like it's integrative
make the patient
exam,
comfortable,
right?
yeah.
Yeah, I'm trying to figure out what's going on by just moving your leg around stuff, and they don't even, but there's all these little tests, I'm knocking the little diagnostic list down in my head, and I told the guy, I said, look, this is coming from back, like you have a 4-5 disc. And he goes, how do you know? I'm like, okay, does it make sense that both your hips were out at the same time and you didn't have any pain a year ago and now you need new hips and they both hurt the same? Like it's upstream, it's coming from somewhere higher, right? And we do an MRI of his back. He's got a big angular tear at 4-5. Like, and he was like, well, are you gonna? He said, yeah. He goes, are you gonna inject it? I go, no. Here's what we're gonna do first. You haven't been on any anti-inflammatories. You haven't done any stretches. You've done no therapy, and you're taking no muscle relaxers. I said, we're gonna put you on a little MOBIC. I'm gonna teach you some hamstring stretches. You're gonna take these. You're gonna go back to Galveston. You're gonna take some muscle relaxers at night. You're gonna do these stretches. And if the anti-inflammatories, because you've been taking nothing, if you take a little bit of MOBIC and you feel a lot better, your body could still heal some of this up. Like you've only been hurting for 3 months, right? But that wasn't even given to him as an option. He was either getting salves or
But you just walk
surgery.
in somewhere and say, yeah, we're going to, aspirate your hip and give you, $10,000. Like, that is insane.
Well, they weren't even going to aspirate his hip. They weren't doing it under ultrasound or guidance or C-arm. They were just going to inject his hip in the office, just pull these cells and just inject it. I said they weren't going to get in your hip.
No.
They were going to inject. They're going to inject something, but and you know what? It might help because a little bit of growth factors can make a big difference. But
Long term, it's not going to help that disc, though.
No,
It's too far away.
I love this. Like for me, if I get to rage against this machine a little bit with someone that's like-minded, it can be very enabling. So I know that for a lot of people, they're going to be overwhelmed by some of this because you trust medicine, just like all of us have at some point. I think that when you have someone that genuinely cares about you, you can tell. Because you can tell because they touch you, they watch you, they have you get up and down from a chair is the least thing you should expect from someone examining you. They should watch you walk. I usually watch people walk in the clinic, and they don't even know I've examined their gait training because I was standing at the desk, and I watch where they walk. I watch how they get up on the chair. You can tell a lot about that.
Oh, yeah.
That's part of the physical exam. If I promise you, if you're seeing Kecia, she's had you get up and down in a chair. She's moved your extremity around. She's touched your muscle. She's done a skin exam. She's paid attention. That's the very least you should expect before someone tries to initiate treatment. So I want to make sure that everyone knows I genuinely appreciate your trust, and we're humbled by your love and trust for us and your care of medicine. I'm going to give Kecia a chance to promote Built For It. I'm a huge fan of what they do, and not. But kind of what they're building institutionally too, because they're developing a thought process based on patient care and sports medicine, and I'm a big supporter.
Yeah, so I like you said earlier, I'm Kecia McKenzie, a co-founder of Built For It, and we have 2 locations. They are big sports performance training facilities, but it's really centered on sports medicine. So we have nothing but doctors of physical therapy, doctors of chiropractic, massage therapy, and performance training. It's a very cohesive group of people. We all work together, but everybody has an individualized plan. So even if you're in the workout groups and there's certain things you can or can't do or need me monitoring stuff, it's just like a constant monitoring of every single person that comes in our doors. So if you've got teams, you need physical therapy, you need training, whatever it is, Built For It's definitely the place to be. So I really appreciate you having me on here because I'm always looking for my team of people, and you've helped me a ton.
Now,
So.
I will tell you that I'm a big fan of anyone that cares about the patient. So it's really few and far between. Thank you so much for your time.
Yeah, you too.